disparities that we see here in Kentucky between different populations. Kara Stewart and I were lucky enough to hear Dr. Michener speak at a meeting in Atlanta last year, and her words really resonated with us. I know. Kara's going to be up on stage later, and I'm sure she'll have more to say about this. But she was sharing research that she had done with Medicaid recipients, and it really helped to explain some of the contradictions that you hear and you sort of observe in what people need and the way that they vote or engage in public programs. And so she's going to shed a little bit more light on that for us. We're going to talk first about some of the ways that public programs like Medicaid can end up creating more disparities or sort of reinforcing certain disparities that we sometimes design programs that in the end disenfranchise people, even though we want to be engaging them and helping them to improve their health. And then we're going to hear from a panel of consumers, Medicaid recipients, who are going to talk about their own experience with Medicaid. And then we'll go back to, how do we design programs to actually decrease disparities, to improve health equity, to empower people. So we're not going to leave you on, after her first presentation, you might feel a little bit down. But do not despair, because we do have options for improving health equity and for designing programs that really work. So we're not going to let you leave here without hearing those solutions. So in any case, I'm very excited to have Dr. Michener here today. She is going to share about this research that she's been doing and really help us explore the ripple effects created by poverty, by racism, by geographic disparities, and other barriers to care that are experienced by Medicaid recipients. And these barriers end up having really far-reaching consequences in terms of our economy and our democracy. So let's give a warm welcome to Jamila. Thank you. We'll take just a minute. Yeah, sorry. Okay.
Look at that. Thank you, Angela.
Yes, thank goodness for tech folks. I certainly could not do it. Well, thank everyone for, I'm really excited to be here, and thank you for hearing me. I'm going to try to kind of streamline this and go swiftly, because I want to make sure there's room for questions if you all have them, and I really want to get to the kind of parts that follow this where we can think productively about solutions. So bear with me as I keep the pace up, but thank you so much for having me. So I just want to say that a lot of what I'll talk about today is drawn from research that I did for my book, which was published in March. And some of it is also based on research that I've done since then that's ongoing right now. So this is really a kind of combination of sources, right? So I think we saw a version of this during Jason and Dustin, right? Excellent. I was really tempted, but I didn't say Justin. A version of this graph for Kentucky, right? And the takeaway was, and this is just for the U.S. And the takeaway was, things are getting better, but also there has been some stagnation, right? In Kentucky and across the U.S., we have kind of lost some of the ground that we gained initially with respect to fewer people being uninsured in the wake of the ACA, right? It's also the case that this varies a lot by state, such that some states, including Kentucky, showed more dramatic improvement than other states, right? And part of what has happened in addition in the wake of the ACA is that there have been these, and not just in the wake of the ACA, but most recently under the present presidential administration, is there have been opportunities to have policies that are part and parcel of Medicaid that are, I think many of us in this room would understand as being not ideal, right, from the perspective of the consumer. So things like work requirements and a host of other kinds of policies that come with some of these waivers that have led to pretty significant, sometimes, I would say crises in a variety of states. Somebody told me the last time I said that, I think crisis is a stretch. I don't think it's a stretch, but maybe reasonable those to disagree. Okay, great. So one of the things that I have been trying to do for many years, even before the most recent period where as we've been facing these waivers, is think about how Medicaid matters politically, right? And not just how it matters politically in terms of legislatures or in terms of politics at the kind of national level, but how it matters politically from the vantage point of Medicaid beneficiaries themselves, right? How experiences with Medicaid, being enrolled in Medicaid, affects the democratic citizenship and political and civic engagement of Medicaid beneficiaries themselves, right? So I didn't really come to this question. This question came to me, or these questions that I pursued in my research came to me. When I was in graduate school, I only knew a few things about what I wanted to study when I got to the point that I needed to write a dissertation in order to get the PhD and get out of there. I knew that I wanted to think about policies that mattered in the lives of racially and economically marginalized communities. And I knew that I wanted to understand the politics of those policies, how those policies affected empowerment in those communities, right? I didn't at this point have a particular interest in Medicaid. I cared about Medicaid because I'm a policy person. I study policy and public policy and poverty, so it's hard not to care about Medicaid, but Medicaid was one among a lot of things that I cared about. And I went into the field and I started to interview low-income Chicagoans. And initially my interviews were very open-ended, and I asked people to tell me about super broad things, right? And part of the logic there was I didn't want to assume that I knew what was going on in people's lives and go to them and say, I already know what's happening in your life, so now just tell me about that thing, right? Instead, I wanted to go to people and say, what's going on, right? How do you think about your role in the broader social, economic, political system? So one of my dissertation advisors said, we need broad questions that you can ask people that will elicit conversations. You can really just engage them and figure out where they are. One of the broad questions I asked at that time was, tell me how you feel about the American dream, right? And this is an example of what one woman, all of the names are pseudonyms, but what one woman, Mabel, told me that turned out to be the kind of response that I got quite often. The American dream, loud sigh. Mabel sighed a lot, actually. She was a big sigher. I don't know nothing about no American dream. The American nightmare is still a fact. I have to go to the doctor every 3 months. I have to have pills every damn day. Sometimes you have to choose between medicine and food. Medicaid, I went, it was just so much I left there. But it's looking like I'm gonna have to go and stand in somebody's line to get some medical help. That's why when you ask me about government, I say I don't know what's going on there. I don't approve. I'm not sure there's something we can do, like vote. It's supposed to be making a difference if you vote. And these kinds of commentary, I wasn't asking people to tell me about Medicaid or to tell me about healthcare initially. I was asking people to just tell me about their lives and how government or politics or policy fit into their lives. And what I found was that again and again, people brought up Medicaid. And I was a little bit intimidated by this initially because the realm of health policy is complex and it's a labyrinth. And I thought, man, if I get into this, it's really gonna take me a lot of startup energy to be able to become an expert in this realm. And so I wrote one chapter in my dissertation about Medicaid, and the rest of it wasn't. I just shied away from it. But when I finished my PhD, I was able to get a postdoctoral fellowship at the University of Michigan at their School of Public Health with the Robert Wood Johnson Foundation. And they literally said, you have 2 years. You can become an expert in health policy at a place where lots of people will equip you with the information and knowledge you need to do that. And so I looked back at the research I did in graduate school and realized that chapter was on Medicaid was the only chapter I liked. It was the only chapter I thought really had a nugget in there that was good, but that we needed to figure out more about. So I started to do research focused on Medicaid and thinking about the effects of Medicaid on democratic citizenship, on civic engagement. And I started by interviewing Medicaid beneficiaries across the country and doing in-depth qualitative interviews, sitting with them for an hour, for 2 hours, sometimes more, and talking to them about their experiences on a kind of person-to-person basis. As a result of these interviews, a kind of broad story emerged, right? A lot of people told me about stigma associated with receiving Medicaid, and they outlined experiences that they had either within the healthcare system itself or outside of that system, just in their interactions with ordinary people out there in the world, that had them associate Medicaid with a certain kind of stigma. And people also talk quite a bit about negative bureaucratic interactions, right? About the difficulty of just navigating the administrative component of Medicaid. How quickly things changed as soon as they felt like they had a handle on how to navigate the system, something changed and they had to figure it out again. And the frustrations that emerged from that, right? So after I interviewed enough Medicaid beneficiaries, and I realized these kinds of experiences were being recounted to me on quite a consistent basis. And I should say as a caveat, one of the things beneficiaries always started with was how grateful they were for Medicaid. How it saved their lives or saved their child's life, and they couldn't imagine not having it. So it wasn't a matter of, people who just wanted, I've had folks who, well, people are just never happy with any services. They just want more and more and more. That's all this is, right? No. Medicaid beneficiaries understood the significance of Medicaid and were perfectly grateful for it, right? But when we got into the nuts and bolts and I asked them about their experiences, right? What's it like when you go to the doctor? What's it like when you go to that clinic? What's it like when you have some sort of a medical issue and it needs to get addressed? That's when some of these other elements of stigma and negative bureaucratic interactions emerged. And that's actually when in my discussions with beneficiaries, they got most passionate. I mean, I would go in there thinking, I'm just gonna talk to people about Medicaid. And by the end of an hour and a half, people are in tears and saying, I've never talked to anybody about this before. People would thank me for caring enough to speak to them because the expectation wasn't that it mattered what their experiences were. And so one of the things that I decided to do at this point was try to get a sense of whether the information that I was getting in these qualitative interviews would map on more broadly if I looked at a larger set of data, right? And so I found a survey that would be useful for this. It's called the Fragile Families and Child Wellbeing Study. It's actually a longitudinal study. I ended up only using one wave that covers and interviews people between 2003 and 2005, because that was just the wave where they asked all the questions I needed to be able to show you the analysis I'll show you right now. But a good thing about this survey is it follows a cohort of 5,000 children and their parents, right? And the interviews, eventually as the children get older, they're interviewed as well. In the initial waves, they're interviewing both parents, right? The main benefit is that these are fragile families, and so they're fragile in a number of ways, either because the parents aren't married, but for the most part because many of the people in the survey are low income, right? And so there are initially about over 9,000 survey respondents, but in wave 3 there are 7,500, a little over 7,500, and 53% of those utilize Medicaid, right? So we have a large group of low-income survey respondents who rely on Medicaid for their health care. So the survey also asked questions about political engagement and participation. Initially, I just wanted to see, does it look like there's a relationship between being enrolled in Medicaid and whether and how you participate in politics, voting, registering to vote, or there's a scale of other activities that go beyond that, like participating in a local political group or a civic group, contributing to a campaign or being a part of a campaign, etc. And what I found wasn't especially surprising, that Medicaid beneficiaries are less likely to engage in these sorts of activities, significantly less likely. Now, in part, a kind of easy explanation is just, well, Medicaid beneficiaries have a lot more life challenges, economic, social, what have you. And this is just a function of that. It's not a function of anything specifically related to their experience with Medicaid, right? Even initially, I was suspicious of that explanation because the survey itself features overwhelmingly low-income people. So many people in the survey have lots of challenges that come along with being economically marginal, but we still see this kind of differentiation. And I should say here, you know, when I measure Medicaid utilization, or Medicaid enrollment, I actually am not just taking into account adults who are themselves enrolled in Medicaid, but also adults whose children are enrolled in Medicaid and therefore are having a kind of vicarious experience with the system, even if they're not themselves enrolled. So that 53% of respondents who are having experiences with Medicaid are either folks who themselves are enrolled or their children are enrolled, right? And what I do to try to kind of figure out, is this just a consequence of economic marginality, or is this really about something to do with Medicaid policy and the program itself, is a lot of statistical finagling. And I won't show you like a whole bunch of charts with a whole bunch of numbers and like stars that show statistical significance, because I get exhausted even by that. But this is just to suggest that, like, so I took numerous steps to kind of work my way through potential alternative explanations statistically here, right? So you could run a kind of standard regression which controls for a whole bunch of other factors to say, when we hold all of these other factors constant, do we still see this disparity between the way that Medicaid beneficiaries participate in politics and the way that non-beneficiaries participate? We can expand the model to control for maybe some of the challenges that we think are heightened in low-income communities, right? We can do matching, which is take people who look very similar on a whole range of metrics, except some of them, one set are Medicaid beneficiaries, the other set are not. So in most of the other ways we can measure, these folks are similar, right? And the differences in enrollment in Medicaid, and do we still see differences in participation? And then this last bit, seemingly unrelated regression, is a way of trying to account for the fact that people select into Medicaid, so maybe there's something about people who enroll versus those who don't enroll that's different, and that explains the outcome. The point is, all of the statistical controls and finagling in the world didn't make this relationship go away. It seemed like Medicaid enrollment had a negative effect on your likelihood of participating in a range of political activities. So one of the things that some of my colleagues said to me, oh, this is bad. You're basically making the argument that Medicaid is bad for democracy. If I want to cut Medicaid, I love your work, right? No. And I take care in the book to say very early on, that's actually not the appropriate conclusion to draw. And the reason is because I go much further than just establishing that there's a statistical relationship. I think about what explains that relationship, right? And in particular, what kinds of policies that connect to the experiences of Medicaid beneficiaries explain it. So this is an example of a woman I spoke to named Terry. Terry's an African-American woman from Georgia. I asked Terry only one thing. We sat down, we were in this like burger joint in Georgia. She asked if I could get her a banana milkshake, got her a banana milkshake, and we had a great, long, very long conversation. And it started with me just saying, tell me about yourself. And she immediately launches into talking about how inconsistent Medicaid is across states and how that's mattered for her experience with the program. And she went through all of the different states that she had had experiences with in Medicaid, in because she moved around a lot, and how in each place she received a different kind of service and had different kinds of experiences. Now, I give you Terry as an example, but this was a theme that came up again and again and again as I did interviews across the country. And not just that there were geographic disparities, but also that within one state there were disparities within state. So a lot of the beneficiaries that I interviewed in Georgia said, well, in Marietta it's this way, and if you're in Atlanta it's this way, and if you're further out in a rural area it's this way. And they had moved from place to place and realized that what you get with Medicaid, the kind of administrative experience you have, really varies based on where you are. within the state, and then once you move across states, that can really affect the nature of benefits that you have access to. Another thing beneficiaries pointed out is that what you get over time differs too, even if you stay in the same place, right? So the policy is always changing. It's changing across space and it's changing across time. It's making it such that Medicaid beneficiaries have experiences of the program as arbitrary and capricious. Last year, I got a PAP. This year, I couldn't. Last year, dental benefits were covered. This year, they're not, right? And that sends beneficiary signals about the broader political context, right? People like me clearly don't matter. You can just yank it away when it doesn't fit the budget anymore, and then you give it back when you feel like we can't rely on the government to provide us with what we need, right? And your need isn't changing. Your income may not be changing, but the policy is constantly changing around you based on factors like geography and time, which from the perspective of beneficiaries are arbitrary, right? And so Terry told me this story about her grandmother, and her grandmother was coming to visit from another state, couldn't get her prescriptions filled. She was really emotional when she was recounting this to me. She said, my grandmother doesn't deserve to be treated like this just because she came to visit us in another state. Well, what kind of state does this, right? And when I asked Terry about the political implications of this, she could express pretty clearly, right, that it signaled a lack of concern from the perspective of the government for people like her, right? John is a man that I interviewed in Michigan, and he had a chronic illness, and that meant that he had essentially, since he was a child, always relied on Medicaid coverage, even though he was from a kind of middle-class family. And he at one point wanted to move from Michigan to Arizona. His doctors had told him, because his illness involves something with his lungs, that if he moved to a more dry climate, he would probably experience better health outcomes, a better quality of life. And some of his family members were moving to Arizona. He wanted to go there. He reached out to Medicaid officials in Arizona and asked them about whether the specific benefits that he needed in order to live would be provided if he moved there. And essentially found out that if he moved to Arizona, he wouldn't be able to get what he needed, right? And so expressed to me just feeling stuck. I'm not where I want to be, but I guess beggars can't be choosers. So I try to tell myself I'll live on Mars the second I have to. You just do what you have to do, and it's not very fun, but okay, unless something changes, that's what we have. Unless there's federal insurance, unless there's another political or policy structure, this is what I have to do. And the whole interview with John, I would ask him about his participation in politics or about voting, and often he just reminded me that look at the position I'm in. I can't even move to where I want to move to. I can't live where I want to live. I can't make choices freely. Like, I don't have power, right? And that message is reinforced for beneficiaries again and again in a number of ways, and they know it's political. Terry says if it was about helping people, you'd say, yes, let my state be more productive and helpful so we don't have people losing their lives, right? And when I asked Terry, well, what can people like you do, right? Is there any route you have to power, to your voice being heard? She says, white noise. I didn't know what that meant, so I just said, well, okay, what do you mean by that? She said, white noise is people choose to say, well, if they give it to me, they give it to me. If they don't, they don't. It means you feel like in your world you have no say in the process if you don't agree with what's going on in Medicaid. And this was a theme that came up again and again and again, whomever I talked to. And given that, the data, the quantitative data that I looked at made more sense, right? So one of the things that I did was I went back and I broke that quantitative data down across states for the states where I had significant numbers of Medicaid beneficiaries, which did not include Kentucky, unfortunately. But what I found was variation across states. And remember, this data is, circa 2000, between 2003 and 2004 is when the survey information is being collected. So it doesn't reflect kind of the post-ACA world. But in places like New York, California, Virginia, all the states below the red line, there's a negative relationship between Medicaid enrollment and political participation. The states that cross the red line, there's no measurable, as per this survey data, relationship. And there's only one state, Wisconsin, which is right above the line, where there seems to be a positive relationship. Now, one thing you can say is like, what? This doesn't necessarily make sense. This doesn't align with how we think about where these states are politically, or their level of generosity, or what have you. When I thought about what explained this, I started to think about aspects of state policy that the beneficiaries I interviewed had talked to me about. So one is expansions or retractions. A lot of people mention this. They would say things like Shanna said, the policy is changing, making it hard for anyone to pretty much go to a doctor. just to get a general PAP exam or any kind of exam. So changes really stand out to people, right? When the program expands or when benefits are taken away. Scope of services is something a lot of beneficiaries mention, right? They could tell me exactly what services they would get if they went with whom, right? With WellCare, I pay for 30% of dental, vision is free since we have bad eyes, I do that. Beneficiaries are very aware of the contours of the scope of services, right? And so when they couldn't get something, they were aware of that. I can't go to the dentist, or I can't get glasses, or I can't go to the podiatrist, right? And then administrative capacity, the idea that the actual experience when you go into a bureaucratic office is, it varies, but many people said it's not sufficient, it's not adequate, there aren't enough caseworkers, I'm not able to get what I need. So what I wanted to understand was, does variation in these kinds of policy features affect the relationship between Medicaid and political enrollment, and explain some of those negative relationships? And what I found was they do. So with respect to participating in politics generally, voting, registering to vote, benefit reductions are the most consistent negative kind of force when it comes to depressing the relationship between, or depressing political participation, right? But we also see it differs across different kinds of participation, but scope of services matters for voting and matters for participating more generally. And so these are the factors, even though the effect of each of these factors differs, the substance, the magnitude of the effect, and also what kind of participation it bears upon, all of those factors matter, and they're aspects of the state policy context that map onto Medicaid beneficiaries' actual experiences, and thus exert a sort of force that disempowers them in many cases. Not in every case, there's variation geographically, obviously. Quickly, I'll just say that the book goes further than just thinking about state policies. I think about the way counties and neighborhoods matter. With respect to counties, I really think about bureaucratic structures and the appeals process, and how that affects Medicaid beneficiaries' ability to exert their voice in a really proximate way, right? I asked people, for example, about administrative fair hearings, and a lot of people expressed hesitancy to engage in these hearings, even when something egregious had happened to them, because they knew that they weren't going to get a significant response, right? So one of the things I looked at, I got data on appeals processes across different states and counties, and tried to see, well, when counties respond more quickly, what do we see? We see more appealing, right? So the bureaucratic structure of the kind of administrative aspect of Medicaid matters for whether people will, even beyond voting and participating in formal politics, whether they'll even push back when something unfair happens to them in the process. And then I find that the neighborhood context matters too. So this Medicaid to politics link I've been talking about, when I looked at neighborhoods across Chicago, because this is where I can get really good data, I found that negative relationship actually varies across neighborhoods. And it's strongest in neighborhoods where people have the least economic resources, but not at the individual level, at the neighborhood level, right? And so where you are in terms of county, in terms of neighborhood, in terms of state, and the policy structure, right, of those places matters for whether or not and how Medicaid beneficiaries engage politically. I also, in one of the latter chapters of the book, found that advocacy matters, right? And in one of the chapters, I focus on activists and advocates who are Medicaid beneficiaries or who are representing Medicaid beneficiaries, like many of you folks in the room. And that is a really qualitative exploration. And what I find is that even a handful of advocates, a lot of my colleagues said, why focus on these folks? They're just little people. I mean, they're not, how big of an effect can they have? And one of the things, and that's why I decided to study it, one of the things I found is even a handful of really passionate, persistent, loud, not necessarily loud, advocates can make a difference for Medicaid policy. And I do a case study of Iowa in the book, and it's just clear. You can identify the kind of 10 people that change the kind of policy landscape in that state, right? Mobilization. So I identified a lot of Medicaid beneficiaries who became activists and interviewed them. And all of them had a story that almost all of them had a story that connected them to organizations, right? Medicaid beneficiaries didn't just wake up and say, I think I'm gonna really fight for my rights here. Instead, they had to be activated, right, by organizations that could tell them what to do, right? Oh, you can submit a comment, you can go to this meeting, you can go to the state capitol and do X, Y. And what I found was the handful of activists that didn't have that organizational connection were much less effective. And then adaptation. So the fragmentation that I just talked to you about, it's different across places, across neighborhoods, contexts, states. That kind of fragmentation is a disadvantage in many ways, right? But organizations play a role in helping the kind of Medicaid policy landscape to adapt to that fragmentation and use it to advantageously when possible, either by learning from other states, right? Implementing things, borrowing things, and by thinking about how to mobilize and strategize and work around that. So I'll end now with just some lessons from my work. You know, the structure of Medicaid in states, but also counties and localities, shape the political conditions necessary to ensure the durability of the program. So as we, have this group of legislators up here, and we're talking about what's possible and policy agendas, part of what shapes whether these policy agendas can come to fruition is the kind of power of people, right, including Medicaid beneficiaries. And this helps us to think about what's structuring that power, which isn't a positive, bright story, but gives us a lens into thinking about change, right? Local institutions and actors are really key for empowering or disempowering Medicaid beneficiaries. A lot of what's happening now is disempowerment, but realizing that local institutions matter is heartening, because it means there's a lot that folks in this room can do. Policy advocates and activists can influence state healthcare systems. You already know this, I don't have to tell you this, but I found evidence of it, which is good. Now you can say, it's not just that I know this experientially, but we know this when we look at data, qualitative and quantitative. Healthcare matters for democracy. Empowering Medicaid beneficiaries matters. Your work matters. It's more crucial than ever before. So, okay, thank you. That's it.
Not at all. In fact, I'm amazed. So we have plenty of time for questions. So I've got them. Oh, that's right. I forgot. Jason.
I'll run.
Thank you.
I'll run.
I have a question.
That was fascinating. Thank you so much. I wonder if your research looked at all at the reasons why people were on Medicaid. And I'm a psychologist. I work with those with behavioral health issues. And it's so fascinating because we've often talked about how hard it is to get people who happen to be on Medicaid because they have a severe mental illness to get empowered, because they have been put down so much by the system of care or lack of care. So I just wondered if you looked at all, besides poverty being a reason, whether you looked at other disabling conditions.
That's great. So one of the things I paid attention to, there's so many things that just aren't on the slides. There are even things that aren't in the book just because there's so much, right? This is just a huge arena and it's impossible to cover it all, but this is really important. I try to think about like beneficiary subgroups, right? And how do these kinds of processes, we can look at the aggregate numbers of kind of all beneficiaries, either adult beneficiaries or adults whose children are beneficiaries, and see these overarching patterns. And the question is, like, what kind of variation is going on across beneficiary subgroups? So one of the things that I found, both in my especially in my qualitative data, but also corroborated by the quantitative data, is that there are certain subgroups of beneficiaries that are best positioned to engage, and that seem to engage in politically and civically more, right? And those are, and there weren't too many of them in the Fragile Family Survey, but there were some of them there. And I've actually used other surveys to try to track this. But essentially like middle class people who are connected to Medicaid for a variety of reasons, because they have a child who is severely disabled, or because someone in the family has like a chronic illness or some sort of condition that means that the kind of costs of Medicaid are just going, or of medical care are going to be too egregious for them to just rely on their private insurance, and they're able to kind of, depending on what state they're in, they're able to actually get coverage via Medicaid. those folks tend to be like the most engaged of all Medicaid beneficiaries, right? And part of that is because they have other kinds of resources. They tend to be better educated, they tend to be better networked, et cetera, et cetera. So to some, you know, what I found certainly in the qualitative data was that quite a number of people in the kind of disability community were actually more engaged, right? But that's through the lens of like not always the kind of disabled folks themselves, but the folks who are interfacing on their behalf, right? The parents, the partners, or what have you. So it really depends on whether you're thinking about the beneficiary themselves or somebody who is a kind of stand-in for them, who's representing them. That latter category, those folks tend to really be more engaged. But the broader point is that there's heterogeneity here across subgroups of beneficiaries, which is why more data and better data, right? So I'm taking a data set that wasn't designed to think about these kinds of things and kind of using it the best I can, and I have 2 or 3 other data sets I do that with. But I think that, you know, I kept getting more and more excited during Lynn's presentation because I thought, yes, the more data we have, better data, continue to expand it and build our database of knowledge, we can get at some of these nuances that are just really difficult to get at using data that wasn't collected for this purpose. Right? I think the mic is coming to you.
Oh, okay. What do you know, right now, previous years and currently, there are so many states that are adopting these Medicaid waivers that require premiums and work requirements and a whole slew of rules and regulations that here in Kentucky I have difficulty understanding. And so I'm wondering what you think about these and what effect it's going to have on people who have now Medicaid. And also, in your surveys, did you make a connection between people's ability to understand these programs and understand the political process and their engagement or lack of engagement in the process, particularly like in voting? I'm sorry you didn't do Kentucky, but I lived in Southeast Kentucky where so many people are on Medicaid, but if they voted, their vote didn't reflect the fact that they really needed this program. They voted against their own interest.
Yeah, those are great questions. So this last question of kind of, so maybe I'll go in order. So the first question, I've been doing 2 things. One is I have some more recent research that I've been doing, or that I've done, that suggests that the effects of the waivers with respect to democratic citizenship, I think, are going to be disastrous, right? And in part because of the kind of administrative burden that these waivers are going to introduce. It's just going to make it more difficult for Medicaid beneficiaries to navigate the system. And all of the evidence that I found qualitatively and quantitatively in the book suggests that also impedes political engagement, right? It just makes things harder for beneficiaries and pushes them to view the government in a light that's more negative, right? So then why do you turn around and engage that same government? And so better not to vote at all, because clearly they don't care about me or people like me and go out of their way to make my life harder. And then it introduces stigma as well, right? There are certain kinds of programs where we need work requirements. We need to watch you people to make sure that you're not trying to get by and live off the dole, et cetera, et cetera. That message is loud and clear to Medicaid beneficiaries. In the last few months, I've been doing more interviews on the ground that don't make it into the book, but allow me to probe what people think about work requirements, for example. And you know, beneficiaries will say work requirements happen because we're at the absolute bottom of the hierarchy. Like, we're just the people you beat on, and they just make our lives harder and imply that we're lazy and we need to be controlled this way. That is, you know, loud and clear to beneficiaries. I don't even have to vaguely like signal it. I'll just say, oh, you know, some states have been adopting work requirements. What do you think about that? And the whole conversation, like, there's a whole set of like really coherent thoughts that a lot of beneficiaries have around that. That's not to say that public opinion polls that have asked for kind of general thoughts about Medicaid work requirements don't show levels of support among the public, right? In part, that's because people love work. So when I ask people, Americans love work. When I ask people, like, well, what do you think about work requirements? I'll say, well, I think work is good. Like, everybody should work if they can work. I'm a fan of that. But then when I say, well, how do you think it's going to affect your experience with the program? I think it's going to be terrible. I think it's demeaning that I should have to do that. Right? So it depends on how people are thinking about work requirements when they're thinking about it in relation to some other, right? Somebody not like me, that kind of like bad poor person, or often in people's minds, a lot of what's going on is like that black person, right? Then I'm all for work requirements. Those kinds of people should be held to account, right? But then when beneficiaries are probed to think about themselves in that light, they talk about it in a way that suggests it will be very individually disempowering, right? I have some work that I've done with a colleague at the University of Missouri, Jake Hasselworth, and we've looked at, because we know one of the things that's going to happen in the wake of these waivers is that a lot of people are going to be disenrolled. A lot of people are just going to lose their benefits. And Jake and I have looked at the consequences of that. We used Tennessee in the mid-2000s as our case study, when hundreds of thousands of Medicaid beneficiaries were kind of surreptitiously dropped from the program because of a decision that the governor, the Democratic governor, had made. And what we looked at kind of within counties before that and after that, what kinds of effects do we see on electoral outcomes, on people turning out to vote? And what we see is that like significantly fewer people turn out to vote, right? Enough so that in an election that was close, which that one wasn't, but had the election been closer, that could have easily affected the outcome of the election. But one of the interesting things we find that speaks to your second question is that, fewer people are turning out to vote in the wake of that kind of policy that disenrolls many beneficiaries. But the people who are turning out to vote aren't necessarily voting in the way that we would expect. In other words, they're not necessarily punishing the governor for having made that decision. In part, into Tennessee, that was because the signal was mixed, because it was a Democratic governor who had done this. But we've been thinking more and more about what explains this seeming quandary, right, of people not knowing, or seeming not to know, and not voting in their own best interest. I think there are a couple things that explain this, like a couple insights that political scientists can bring to bear on this. One is just the kind of increasing importance of negative partisanship, right? The idea that my party is right, my party is going to save America, anybody who's a part of the other party is wrong and is going to be the death of America, right? It's not just like, well, reasonable people disagree, and I'm willing to vote for another party if there's an issue that really matters to me that I want to see change on. Instead, many people are just voting party and could not imagine doing anything other than that. And so even if the party that you agree with on every other metric is going to take your health care away, you can't imagine voting for the Democrats, right? And so, I mean, it's the perfect example, I think, is Roy Moore, where it's just like, I don't know if there was child abuse involved, but there's no way I'm voting for a Democrat, right? And it's like, wow. For many people, political social scientists are finding more and more evidence of this. There's essentially nothing that can convince them to vote for anyone who's not in their party. And that's why we call that negative partisanship. It undermines what are supposed to be the benefits of partisanship, the kind of democratic benefits of partisanship. And it gives parties cover to do a lot of things that aren't good for their constituents. Because you know what? Most 90% of these people are just going to vote Republican all the way down the ticket. Doesn't matter what we do. So let's do what we want to do. Let's follow the special interest, right? And the other thing is, and political scientists have found a lot of evidence for this, and it connects back to what I said before. Even for people who rely on Medicaid deeply, right, they still have stereotypes about the program, about who it benefits. And many people, when they're thinking about taking away Medicaid, they don't want to lose it themselves, but they sure know other people who they want to lose it, right? People who live in those other counties, people who don't look like they do, people who they imagine are not as worthy as they are. And that kind of set of processes doesn't go away for beneficiaries, right? They internalize the messages, the broader messages that we have in society about people living in poverty and different racial groups. And that affects their decision making, even when it affects their decision making in a way that seems antithetical to their own interests. Their understanding of their interests, different than our understanding of their interests, right? Or at least their prioritization of their interests. So.
Let me do a check on the
We
time.
warned you that this would be
We have a little
depressing.
more time. I know it doesn't look like it, but
Oh, no, it's a,
we did.
yeah, it's okay. But,
We got lots of hands.
yeah,
I'm sorry, you're the first one, so it's just.
We're gonna start our next session at 1:45.
It just seems so counterintuitive that people that feel helpless don't do anything to make it be different. There are two ways to look at that in Medicaid. One is that you could actually try to make Medicaid be more consistent. But is there another way that the culture could? Could you influence the culture in a way that people would feel differently about that?
Yeah, I mean, I think the answer to that is yes. And I think a lot of that depends on what happens in the kind of like civic and organizational world, right? So when people are faced with a scenario where there is a political reality or a policy reality that disadvantages them, that makes their lives harder, and they have a choice, take action, do something about it, right? That the thing that's been flashing, vote like your family, your life, your health, everything depends on it, right? People could do that. They could say, oh my gosh, these experiences I'm having are just unacceptable. I'm going to take action. Or they could say, for a system to operate like this, people like me have to not matter. So why should I engage? It's not going to change anything. And I have limited energy to expend, limited time, limited emotional wherewithal. And so if what I'm going to do isn't going to affect this system, I'm not going to do anything. I'm just focused on making my own life work. And so in one way it's counterintuitive, in another way it's very intuitive. The question is, how do we shape what kind of reasoning is most appealing to beneficiaries, right? And part of how you do that is to introduce them to a broader civic infrastructure that takes them out of their individual experiences, which may be very negative, and disempowering. Little old me, I can't change anything. I can't even go into the Medicaid office and get what I need from them. How on earth am I going to do anything to change the policy? It makes perfect sense. Every step of this process has proven to me that I don't matter and that I have no power. So why do I go further and do even more, right? No. Unless you encounter someone who tells you otherwise, some organization, some set of people, and who show you a way. Actually, there's going to be this hearing at the Capitol. Your story matters. Can you come and speak at it? Actually, there's a comment period. We need people to comment. It matters. Can you do that? Actually, we're having this local meeting with a political representative. Having more people with your experience there will make it better. Can you do that? We will arrange transportation, right? So mobilizing people through organizational conduits that provide them with support and resources and knowledge about how they can engage is the best path forward. Because if it's just about people learning from their experiences and intuiting from that point, they're going to intuit that there's no reason, there's very little payoff for expending their energy on trying to change this.
I appreciate you briefly touching on the partisanship question with regard to Medicaid as an issue specifically. And I'll keep it really short and just ask, do you go into depth on that in the book? I know you covered everything else a lot more in depth, but I'm curious if that's something that we could read a bit more about if we have a strong interest.
You know what, there isn't actually much in the book about partisanship, and this is something that's come up as I've given talks with people, but Claudia, you don't say enough about parties, right? So there's a couple of reasons for that. One is just because there's only so much you can fit in one book. But the main reason is because I make this clear at the outset of the book, that the direction I take in the book is largely driven by what beneficiaries tell me. I want to understand how they view the world, right? And a lot of the beneficiaries that I interviewed, they certainly had like partisan attachments. That's not what they talked about. When I asked them about Medicaid, why they engaged, how they engaged, why they didn't engage, what was holding them back, hardly anyone mentioned partisanship. That's not to say that it doesn't matter, but it is to say that there were a lot of other reasons that they foregrounded before partisanship seems to even come to mind. And a lot of people would be ambivalent about it. They'd say, you know, I'm a Democrat, but I don't really think the Democrats are doing this right either. Or, you know, a lot of people in rural upstate New York, where Cornell is located, so I was able to interview a lot of folks there, would say, and I had some research assistants, I actually had some research assistants that I trained who were white, because actually in rural upstate New York, people were very hesitant to talk to me. They're like, I don't know if I want to talk to you about Medicaid. But when I sent my research assistant out, who was like a very sweet young white woman, people were like, please, can I talk to you? She got a totally different reception than I did. And she was able to sit down with people and ask them, and a lot of them, yeah, I'm a Republican, but I don't really see this as a party issue. Now, do they hold to that when they go to the polls? Like, not necessarily. But in the sense, like, in how they describe their experiences, people are thinking about Medicaid, and they're drawing conclusions, and everybody is implicated in many people's views. Democrats, Republicans, none of those folks are representing them and doing things that are in their best interest. That's what many beneficiaries express. This isn't about parties, this is about the government. And the government doesn't care about people like us, and that doesn't really change no matter who's in power. That's not necessarily true, right? Especially depending on where you live. But until beneficiaries are engaged in a community, a civic and political community, that can help them to understand how those differences matter, they assume that parties don't matter, that everyone's equally implicated, and A, are less likely to go to the polls, and B, when they do go to the polls, just vote for whatever party they like. Because they don't think that party's any more at fault than the other party. Everybody's at fault. So I'm just gonna vote Republican or vote Democrat like I always do. So it's a complicated thing, but it doesn't come up in the book because beneficiaries don't bring it up when I talk to them. If I prompt them to, they will, but it doesn't come up organically because it's in their minds.
That's actually a really good segue to my question. Can you talk a little bit about how the Medicaid system creates or breaks trust?
Wow, that's a great question. I think, so one of the things that's helping me get at this question now is some work I'm doing with a colleague of mine at Duke at the Sanford School. And she studies other policies. Chief among them is WIC, the Women, Infant, and Children Program. And she came to Cornell to give a presentation last year, and we sat down and we started talking, and we realized, like, she was interviewing lots of WIC beneficiaries. I was interviewing lots of Medicaid beneficiaries. There's lots of overlap between those two groups. But when she was asking people about their experiences with WIC, they weren't saying anything like they were saying when I was asking them about their experiences with Medicaid. Even though it's largely an overlapping group of people, very different experiences. And part of the reason why is because, you know, built into WIC's design is the sense that, like, if we're gonna provide people with nutritional assistance, we kind of have to know things about their lives. We're engaging in a way that's trying to understand where people are and then help them, right? So in other words, it's about a kind of, we think about it in terms of the difference between a people-changing organization. Let's try to understand what's off in people's lives, what's preventing them from having nutritional health in their children, and let's try to offer them resources to change that. People changing versus people processing. There's a benefit, you get this benefit when you come into this office, here you go, now move on with your business. And Medicaid is a people processor. It's churning people through, and people know that. They, again and again and again, one of the phrases that comes up most in the interviews, I felt like I was just a number. There is not a kind of engagement that allows for the development of trust. And many people say when you go into some offices now, you don't even talk to a person. You go in and they say, go fill out that form at that computer station.
Yep.
And if you don't, you're like, I don't know how to work that computer. Can somebody help me? Go try first. Even just to talk to a person requires jumping through. That's not how WIC operates for the most part, although with the caveat that there's variation across place here, even within a state. But there's so little opportunity for trust development in many Medicaid bureaucracies. It's just not even a question. And one of the things that WIC shows us as a counterexample is that it's possible for a means-tested program to do this, but Medicaid isn't doing it. It's not the approach. It's a processing approach. We got to give you this thing, come on, get through. Versus, like, how can we think about the resources that you need in your life in order to be living in a more healthy way and provide you with those resources and provide you with them in a way that kind of reflects a kind of humane interaction, right? That makes you feel like you're a person that should matter. And many Medicaid beneficiaries, when I get in the office, I get the idea that I need to say what I have to say as quickly as possible and shut up, because they don't have any more time than that. There's no trust there. There's no trust. And then there are also racial dynamics and that I talk about in the book, but I didn't talk about as much in the presentation. And especially for people of color, there's even less trust, right? Because there's this sense that we are at the bottom in the Medicaid office. We're at the bottom. Everybody else who comes in is going to get better service. We're looked at in a different way. A lot of, especially African-American women said to me, we're looked at it in a different way. We're not there because we're having a hard time in life or because some difficult circumstance arose. We're there because we're leeches and we just want to live off the government. And that's how we're viewed and that's how we're treated. And beneficiaries look around, they can see the person who's going before them and they get a sense like if there are differences in how they're being treated. And nearly all of the people of color that I interviewed brought that up, right? And interestingly, the white beneficiaries that my research assistants interviewed, and some of whom I interviewed, would say, yeah, Medicaid's pretty bad. It's probably worse for black people than it is for me. I have a few beneficiaries who said that explicitly. And so, which that was always surprising for me, but so that also impeached trust, right? And same thing with kind of immigration status. So some of the people that I interviewed a few people that I interviewed, Latinos who had accents, said, when I go in the office, I try to tamp down my accent as much as I possibly can. Anything that marks you as different and potentially less deserving. And interestingly, gender, the male beneficiaries I interviewed said, I walk in the office and they're immediately suspicious of me. Why are you here? You're a grown man. And I don't see any little kids with you. You shouldn't need this, right? And especially if they had like a chronic disease like John, who I had a quote from. He's like, I walk in and I'm just being judged because I look like a middle-class white guy. I am. And in many people's view, I shouldn't be there. And so there are so many things that impede that trust.
It's our last. We have time for one more?
Yeah, we have time for a quick one.
We wouldn't deny
And I'll
care.
respond quickly,
Yeah, I
I promise.
promise.
I'm afraid to deny care of
That's
my.
all.